Thank you for allowing me to present. My name is Andrew Ngov, and I'm an undergraduate senior at the University of Notre Dame. I was given the opportunity to do research at the Division of Minimally Invasive Surgery at Baylor on this topic. Is reoperative surgery safe for magnetic sphincter augmentation? I have no disclosures. Dr. Lees is a consultant for Ethicon, and none of the other authors have disclosures pertinent to this. Gastroesophageal reflux or GERD affects 30% of the U.S. population. Medical therapy with proton pump inhibitors have a limit to the relief they can provide for symptoms. Surgical options have been used as a first-time line treatment for GERD or when medical therapy fails. Fundoplications are the gold standard treatment, but magnetic sphincter augmentation has provided a viable alternative. For magnetic sphincter augmentation, the current implantation recommendation is a two-step procedure. The first step is a complete mediastinal dissection with a curvoplasty. That includes repairing any hiatal hernia that is present. The second step of the operation is the implantation of the device. The current uses for magnetic sphincter augmentation are treatment for GERD. There have been many publications, and the first implant was in 2007. The biggest publication was in the Clinical Gastroenterology and Hepatology Journal. That was in 2007, but numerous publications have been published. Later in 2017, we went away from our minimal dissection to include the two-step procedure I just described to include GERD for patients with hiatal hernias. That was one of their significant publications. Next, the treatment of Barrett's esophagus clearly needs some more investigation, but has been shown to be safe in 2019, for which there is a publication. We published our own findings on LPR when GERD is present. You can use the MSA device to treat LPR, and that was published in 2019. For patients that have had bariatric surgery, there have been a few publications with very low numbers that show feasibility. We set out to look at the use in prior gastric surgery. Prior gastric surgery includes bariatric surgery and prior anti-reflux surgery. We compared that to a large cohort of patients who had primary anti-reflux surgery with MSA. We had 3 total groups, starting out with a total of 103 patients, 82 patients in the primary surgery group, 21 patients in the prior gastric surgery group. And we did a subset analysis of 11 bariatric surgery patients and 10 prior anti-reflux surgery patients. These are the 3 groups we focused on. The patients that fit into this category, a lot of them had 1 fundoplication, a couple of patients had 2 prior fundoplications, 2 patients had a TIF, a lot of the patients had sleeve gastrectomy, 1 had a duodenal switch, 1 had a sleeve to bypass, 1 had a bypass to bypass reversal, and 1 patient had a fundoplication to sleeve. Our demographics do show a significant difference between the 2 groups, but it probably does not affect the actual study itself. The age is slightly higher in patients that have had prior gastric surgery. This overwhelmingly favors female in the prior gastric surgery group. The patients undergoing regularly anti-reflux surgery are split half and half, which is what we expect. The BMI is about the same. In comparing ASA, the more sick patients fell within the prior gastric surgery group and the regular surgery group. This is expected as patients who have underwent prior surgeries are usually sicker than patients who are in for one-time surgeries. Preoperative assessment for patients in the prior gastric surgery group. This is preoperatively. We show that the difference lies mainly between patients who have a higher LES residual pressure in the prior gastric surgery group, and that is usually because the compliance of the stomach and distal esophagus is altered with a fundoplication wrapped around the esophagus, or they have a sleeve. We expect that to be a little higher in that group. The patients in the prior gastric surgery group had more esophagitis, so they were higher in this group and lower in the no esophagitis. The hiatal hernia size was slightly higher in the patients with prior gastric surgery. Intra and postoperatively, which were our main primary endpoints. For the post-gastric surgery group, we recorded a higher estimated blood loss, but I'd like to point out that it's not that high. It is what we were recording as slightly high. There are typically longer OR times. Here's the mean OR time, which is significantly longer. There's a higher number of MSA beads, so the devices we are implanting in these patients are slightly bigger. There are more patients staying overnight, which is what we expect in patients undergoing redo surgery. There's typically a little more pain associated with it, and so they usually stay overnight as opposed to the primary surgery patients, which are usually outpatient. Despite all this, they still have the same postoperative quality of life scores and RSI scores, meaning they have the same outcome. They have the same satisfaction, the same amount of patients returning to PPI therapy. So for patients failing the surgery, there was no difference. For the same number of devices that had to be removed, there's no difference. Those are the four last categories here, and there was no statistical significance in outcomes. We did a subset analysis of the patients in the prior gastric surgery group, looking at bariatric surgery and non-bariatric surgery patients, which is essentially anti-reflux surgery. There is no difference between the two groups except the non-bariatric surgery patients stayed overnight at a higher rate, which we'd expect. If you are doing redo anti-reflux surgery, almost all of those patients stay overnight. If they have prior bariatric surgery, sometimes there are not a lot of adhesions and the surgery goes uneventful and they can go home. I would expect that. The amount of patients on PPIs was not very significant. 3 of the 10 non-bariatric surgery patients went back on PPIs. Overall, there's no difference between the two groups. In conclusion, it is safe to use magnetic sphincter augmentation after prior gastric surgery. You should expect the same outcomes, but need to be highly selective in who you put the device in, just like the patients who have had no prior gastric surgery. You still need a diligent preoperative workup. Despite the longer OR times, the higher estimated blood loss, and more patients staying overnight, these are all expected differences based on the nature of the surgery. This reinforces prior studies on bariatric surgery patients and gives an indication that prior anti-reflux surgery is safe and feasible. Thank you. Now I can take any questions.